Truls is an associate professor in sociology at the UiT, the Arctic University of Norway. And luckily, he also holds a position as a researcher at our center. Truls' research interests within the field of e-health is why some institutional changes succeed while others fail. Sociology studies the prerequisites for the emergence of and the interaction between society's various elements. This social science can help us understand the digital divide. So we really look forward to Truls' presentation. The floor is yours.
Hello, my name is Truls Tunby Kristiansen. I'm a researcher here at the Norwegian Centre for e-health research. I'm also an associate professor in sociology at the University of Tromsø. And I have been asked to give a presentation on today's topic, which is the digital divide or digital inequality. And as this is a complex issue, my offer today will be to introduce some concepts that I believe are powerful concepts, and that I hope that will help us to grasp today's topic in a better way. And as a sociologist, I naturally turn to my own discipline, to sociology, but at the same time, I have tried to make this presentation accessible and useful to those of you who are also not sociologists, of course. So this presentation is about the Nordic paradox, or more generally about persistent health inequalities. And it asks whether e-health can make a difference in this situation. In order to answer this main question is, of course, we have this situation with persistent health inequalities, and in the Nordic model we call this the Nordic paradox. And in order to answer this main question of whether e-health can make a difference, we first need to know a bit about these two terms. So we need to ask two other questions first. And the first question then is, what is health inequality, or more specifically, socioeconomic health inequality? And the other question is, what is the Nordic paradox? So to the first question, what is health inequality? There's a rich sociological literature on so-called socioeconomic health inequalities. And this literature points to the fact that health is socially distributed. That health is socially distributed means that different social groups tend to have different health outcomes. And it also means that this is typically linked to the group's status or position within the societal hierarchy. For example, groups with high education or groups with high income generally tend to live longer and have better health outcomes or better health than low education groups or low income groups. A really striking and classical example from the literature is linked to a classical study of a large US corporation where researchers followed this company for several years, and they found that the health outcomes of the employees in this company correlated perfectly with their status within the company. So those on the top lived longer, those on the bottom lived shorter, and the gradient was perfectly between these. So the status and the health outcomes actually correlated perfectly. This was also called, in this classical study, the status syndrome. So it is well established within the sociology of health inequalities, that health is socially distributed. So the next question, what is the Nordic paradox? Also here there's a rich literature in the sociology or social sciences about different welfare state regimes or different welfare state types. The literature typically distinguishes between the Nordic welfare model, the Anglo-Saxon welfare model, and the continental welfare model. There have also been some additions lately, but these three are the classical typology developed by Gösta Esping Andersen. And in this typology, the Nordic model is seen as and found to be particularly successful in reducing most types of social inequality. However, research has also found that health is an exception to this pattern. And the finding is that Nordic welfare states have actually surprisingly high levels of persistent health inequality. So, what are the building blocks of this Nordic paradox? We can say that the first building block is this generous and universal welfare state model. This is the characteristics of the Nordic welfare state in the Gösta Esping Andersen typology. The Nordic model is general and universal. That means that it caters high-level services to all. Universal, but universal means that it caters services to all, and then it is generous, means that it caters high-level services. And in this model, the finding is that most forms of inequality, social inequality, for example, economic inequality, for example, educational inequality, gender inequality, other types of inequality are comparatively small, and they are generally smaller than in the rest of Europe. And based on this, the expectation then, of course, is that also health inequalities should be smaller than in the rest of Europe. But here comes the paradox. The paradox of the Nordic model is that health inequality stands out as surprisingly high and persistent and even increasing. And based on this Nordic paradox, our main question can now be rephrased as, will e-health help to decrease this Nordic paradox, the Nordic paradox of persistent health inequalities? Or will we just get a new and digital version of the same paradox? So, in this constellation or this situation, what is the promise of e-health? We could start by asking, why do countries strive to digitally transform their healthcare sectors? What is the point of e-health? The expectation, of course, the reason why countries do strive to digitally transform their healthcare sector is that it's supposed to lead or expected to lead to better healthcare services, but also to more equal access. Better healthcare services, more effective healthcare services, and more equal access. And both these expectations are interesting and important. But today, in line with today's topic, we're going to focus on equal access. And to most of us, it might seem self-evident or obvious that equal access to health-promoting technologies would lead to more equal distribution of health benefits, and that this would also then lead to reduced health inequalities. However, as health sociology has demonstrated time after time, both within the field of e-health and in almost all other domains, social domains, the tendency is that privileged groups almost always benefit more when new opportunities arise. As in all other contexts, the rich, the educated, and the otherwise privileged groups tend to reap the greatest benefits when new opportunities arise. And in sociology, this is often called the Matthew effect, or the Matthew principle. This is a term that was coined by the sociologist Robert Merton in 1968. So it's a rather old concept or reference, but it is actually even older. It is actually a biblical reference. No, I'm no biblical scholar, but as I remember, it goes something like this. He who has shall be given more, so that he has abundance. And he who has little, from him shall be taken away, so he has nothing. Something like that. Of course, in a more technical sense, this is about accumulation of benefit and about accumulation of disadvantage. So, how does this principle apply to the field of e-health? The central idea of the Matthew effect, the Matthew principle, is, as I've already stated, it is about accumulation of benefit and accumulation of disadvantage. We know that, for example, digital literacy, which is a much used concept in e-health research, we know that digital literacy or digital competence is also socially distributed. It is distributed along factors such as education. The highly educated have higher digital competence, tend to have higher digital competence than the lower educated. It is distributed along age, for example, and it is also distributed along factors such as income. So privileged groups tend to have more of this resource of digital literacy, and this difference benefits the privileged groups, according to the Matthew effect. We also know that social capital, for example, family networks or other networks, may actually protect individuals against digital exclusion. For example, something as simple as having a daughter or a friend who can help you getting online to perhaps check make an appointment with the doctor and such simple things. This is also socially distributed. So some groups have stronger networks than others, and this difference benefits, according to this Matthew principle concept, this difference also benefits the privileged groups. We also know that cultural capital matters. Mastery of language is obviously important. Knowing how to navigate digital welfare systems or welfare systems in general, knowing how these systems work, this knowledge matters, and this knowledge is also socially distributed. Resourceful or privileged groups tend to have more cultural capital, and according to this Matthew effect concept, this difference also benefits privileged groups. We also know that material inequalities persist in spite of well-developed welfare regimes. Material inequalities persist and in some cases also increase. This means that both access to technology, digital devices, to internet access, it actually varies. We know that. And we know that this difference will benefit privileged social groups. We could also talk about geographical differences. There are many distinctions here. For example, if we talk about geographical differences, we know that in many countries, including Norway, high-speed internet access varies geographically. And in line with this Matthew effect concept, we can easily see that this difference also benefits privileged social groups. So, boiling all this down to trying to arrive at some kind of mechanism, we can see that this is about, we could say that this is about inclusion leading to more inclusion. If you are included, if you have the resources to be included in the use of these digital healthcare services, e-health in general, then inclusion leads to more inclusion. At the same time, exclusion leads to more exclusion. If you lack the digital competence or digital literacy or cultural capital or access to digital devices and so on, this will lead to more exclusion. And this is the heart of the Matthew effect, as Merton coined it, and as this concept has been used in sociology since. Exclusion mechanisms that work over time can explain how different social groups the difference between the gap between different social groups actually increase. So, how can this concept of the Matthew effect orient action to reduce the digital inequality, which is, of course, today's topic? First of all, this concept of the Matthew effect teaches us that privileged groups almost always benefit more in all sectors, all areas of society. This happens also in e-health, and it happens spontaneously. You don't need political, you don't need interventions to make this happen. This happens spontaneously. But the effect also teaches us, we also might understand from reflecting on this concept in relation to e-health, that it might be possible to actually counteract the Matthew effect and actually reduce health inequalities if we find the right entry points. And I believe that this concept can also orient this work to try to spot this correct or this most useful entry points for efforts at reducing health inequalities, or the inequality producing potential of new digital technologies. So some of the lessons, there are many lessons to be thought to be taken from this, but some of the lessons generally might be that efforts by decision makers and also service developers needs to be placed on groups, social groups, who for some reason risk benefiting the least from e-health. Efforts needs to be placed on vulnerable groups who risk benefiting the least from e-health. And it also means that evaluating e-health, we need to measure e-health initiatives, e-health services, programs on their ability to help users with low education, for example, low income, and or weak social networks. We need to put effort into ensuring equal access to technology, regardless of income or education. We need to promote digital literacy in the whole population, and we also need to offer easily accessible and high-quality health information. This also goes for the service designs. It needs to be easily accessible, intuitive interfaces, and easily accessible, so that vulnerable groups can also make use of this information and these services to improve their health. So generally, I would encourage you to use this concept, this Matthew effect. It's a simple concept, but I believe it's a powerful concept, and I encourage you to use this concept as a lens for observing how also e-health and digital healthcare service initiatives might actually, in some cases, create or increase health inequalities. But of course, most importantly, I would use this concept. Some of the value of this concept is that it might help us to see and identify ways in which decision makers and also developers may counteract the Matthew effect. How to find these entry points? How can we actually develop this in order to counteract this Matthew effect, which is so pervasive and powerful. So the goal, I think, overall is the goal, the thought behind this presentation or this initiative is, of course, that we all want to realize realize this equalizing potential of e-health. There's a great socially equalizing potential of e-health. This is also some of the reasoning behind or the justification of many e-health initiatives. It is supposed to work socially equalizing. And I would point out that this is not just a matter of fairness or justice, because better reach, more inclusive e-health, digital healthcare services also means that the healthcare sector will get a better function. It will serve society better. and then help to transform the healthcare sector to improve the healthcare sector's function to society, which of course is the point of e-health. So that's my presentation. Use this concept to view e-health and have a special eye on these social groups that are so easily left behind when new opportunities arise. Thank you.